Hey there, it's Gabrielle Nicolay from Speech Kids and Raising Orchid Kids, where we teach little kids to talk and help parents understand their kids. And I'm back with Karese Laguerre. Karese, nice to see you.
It's so good to see you. I'm so happy to be here.
Today, we are going to sort of drill down on a little bit of a narrower topic. But last time we talked about sort of myofunctional therapy in big. Now, all of a sudden, because I said your last name, I'm thinking in French. We sort of took a very bird's eye view about breathing and myo. Let's go sort of into this question of tongue tie and talk about tongue, maybe lip ties too. So first of all, what is a tongue tie?
All right. So we all have frenums. Frenums are little connective tissue pieces made mostly out of fascia that connect the base of the tongue to the floor of the mouth. So everybody has one. I think most people are surprised when they lift their tongue up. They've heard about tongue ties and they're like, oh, I have one. The presence of a frenum does not mean that you have a tie. What would make it a tethered oral tissue, ankylglossia, or a tongue tie is that it is short or restrictive. So it would inhibit or prohibit certain functional activity of the tongue. The tongue might not be able to elevate, protrude, lateralize, cup, round. I mean, there's so many different things our tongue can do. A lot of it we use when we're talking and trying to produce speech. We move the tongue in a lot of different ways, but we also use our tongue when we're breathing, like we talked about last time. And we use our tongue just as like an oral cleanser. So we need that tongue to be freely mobile.
And if it's not, I'm hoping you can't really hear my dog barking, but he is barking quite a lot. If it's not mobile, if the tongue is tethered, the tissue is tethered, so what?
There is a myriad of things that can result, but let's start from like the very, very beginning. So let's start with very early on in life. You're a newborn, you need to eat. Well, looks like those newborns are very, very developed and primed to feed through breastfeeding or bottle feeding, but they have to suckle in order to feed. When it's breastfeeding, that's hung. It's got to come up, it's got to compress against the nipple, and it's got to have this peristaltic, like wave-like motion going on. And then we're using those buccal pads in the cheeks to really get that liquid to come and to express out of the breast tissue. And so that tongue, if it's restricted, is going to make that a lot more difficult. They may not be able to gain the functional capacity to latch and to feed well. And so that'll create a problem for baby, one, because they won't be able to feed properly. They may not get enough. They might not get enough nutrition. Or mom could be experiencing issues with pain during breastfeeding or an inability to adequately produce. I mean, it's a problem on both ends of the spectrum. So we never want to just look at the one side of it. We could dive into a little of the lip ties there.
Go ahead, do it. Yeah, because no, but this is really interesting, right? Because this suckle response is something that babies come pre-wired to do, but it does depend on the tongue being able to elevate and then stay there and do its back and forth kind of thing. Yeah. And so if we're just getting the up and down because we're not able to sustain that elevation, then we're going to have pain. Mom is going to have pain. Baby's not going to have pain. Baby's going to have pain because they're hungry, but mom is going to have really, really sore nipples. And that's where I think a lot of people, they say, it doesn't work for me. I'm going to switch to bottle feeding, which is a completely legitimate choice. But that also, and I want to go back to, we're going to go back to lip ties in a second, but I also want you to talk about when we switch kind of, it's not willy-nilly, but when we make that decision to switch to bottle feeding, like how that masks some things. Yeah.
Absolutely.
But okay, so the second thing that you have to be able to do if you're going to nurse is flange your
that lip to flange. Yeah. So that lip has to flange up and over. You've got to grab enough breast tissue. And so the baby has to have like a wide gape. They have to be able to open. And so the lip tie is really just that frenum that is right on the gum margin, and it connects between the gums and the upper arch and the inside of that upper lip. So that's going to connect those two. Everybody has one. Don't be worried if you see one, okay? But if the baby is unable to get that lip to up and over, it's going to be a problem. So that's when we need to, you know, allow for some release there. Now, just to get back to what you wanted to talk to before, when we make that switch from breast to bottle feeding, two different mechanisms of action, completely different mechanisms of action. There is, to date, no matter what the marketing says, no really good bottle that mimics or imitates a human breast. The marketing is phenomenal. I mean, I also love total tangent, but I also love the marketing for all of the pacifiers that say that they're like dentist approved. There are 0 dentists I've ever met that have approved a pacifier, but that's neither here nor there.
I love it.
The bottles.
We'll do that another time.
Exactly. The bottles do not actually require a lot of that action from the tongue. In fact, the way how we are able to get some milk out of the bottle so that we can test it, you really just turn it over and it starts to drip out. The baby doesn't have to do much work at all in order to get it. So you could find a compensating pattern that results as a result. They're unable to adequately breastfeed.
Was that yours?
Sorry, my dog. Yeah.
But this is going to be the dog episode. No worries. We're just going to.
They're unable to adequately breastfeed, and therefore they're just going to have their tongue in a lower position. It won't be able to, you know, mechanically move in the same way. They're not going to get to that mature swallow in the same method that a breastfeeding baby might.
And the reason this matters so much is because when infants are developing, there are some things that, like, there are some precursors that need to be in place for chewing solid food, for speaking, and for whatever we need to use our mouths for, mostly speaking and chewing. But okay, if we don't progress through those steps, there are going to be gaps. And it's not that baby's not eating well, because bottle-fed babies eat well. They get a lot of milk because the milk is kind of just coming to them. But we may be setting our infants up for a failure later. And this is where I see them, is like, kiddo didn't transition from purees to solids. And now we think we're looking at a feeding problem, like a picky eating that developed in toddlerhood. It didn't develop in toddlerhood. It developed a way long time ago.
Exactly.
And then we also have, so I want to just pick up on this low tongue. Anytime you've got a low tongue, then we know, first of all, there's mouth breathing, so refer to previous episode. But if we have a low tongue is not ready to do all of the acrobatics that it has to do in order to have clear speech. So there are direct links there between infant feeding and toddlerhood and childhood. Yeah.
Exactly. That's why all these milestones are there. You know, they have to progressively get through them. And if we think about it as anatomical as we can, think about it as the fact that we have 8 different muscles in pairs. So that's 16 different muscles innervating that tongue. Any of them are kind of slacking, and, you know, you're not going to have that muscular ability to be able to functionally use the tongue in the way that you want to.
Okay. So here's my question. Most of us have functional speech, we have functional eating, and some of us might still have a tongue tie.
Ooh.
And I know, right? Okay. And maybe our breathing is pretty good. We're sleeping well, we're learning well. So if we have a tongue tie and no clinical manifestations, what say ye, Karese Laguerre?
I love this. When you have something that looks like a tie, it could be short, it could be restrictive, you might elevate that tongue tip and it totally curls into it itself, looks like it's a butterfly lifting up, but no functional issues. It's not a tie. It's not a tie. It's not a restrictive or tethered oral tissue. Without the dysfunction, it's just not a tie.
Now, this gets really interesting for me because the questions in childhood maybe are a little bit different from adults, right?
Totally.
Which is like, and I'm curious to hear your point of view on this because I don't really have one other than being not very interventionist. But if you're seeing a child who is presenting with this type of restriction where they can't elevate, where their tongue is curling, are you thinking as a clinician, it's pretty early, we want to set this child up for success later? Or how do you think about that?
When I see them and I see what looks like a restriction, but I'm not seeing any dysfunction at that current stage, I definitely want to keep a good eye on the situation. I don't try to do anything in a preventative way because if there's no dysfunction, there's nothing really for me to be working on, right? But what I would say is that I want the family to be aware of all the possibilities of things that could come up in the future. So in the future, if they are experiencing any head and neck tension, if they are experiencing more forward, or they're seeing and they're watching and noting that there's more forward head posture, open mouth, low tongue posture, are you noticing any increases in the snoring? Is there any bruxism, clenching, grinding? What's going on? Just be aware of what could all present later on. And if you see any of these signs, let's circle back around and reevaluate function and then look at what we might need to do as a result.
Okay. All right. So let's assume then, let's go back to our little baby guy who is not nursing well. What do we do? And we've found that there's dysfunction, there's a tongue tie. What do we do?
Okay. So we found and diagnosed, so the release provider, the dentist, the physician, somebody has diagnosed this tongue tie. And then second step is always to see a functional specialist, feeding therapist, or a lactation consultant. Okay. Never just go straight to getting it released. You never know what you might be able to accomplish just with some functional work. So,
I'm going to pause you there. This is so important because we have structure and we have function. And this is what we've just been talking about too, as regards, we can have a tongue tie and that's structure. And we can have a lot of impact on function, meaning how things move and work, or no impact on how things move and work. So we're always looking at both. And I so appreciate you saying, because here's the thing, most medical professionals are looking at structure. They're not looking at function necessarily. They're looking at a standardized measure. They want to measure. They want to say, oh, this is X millimeters. We got to chop it off. So we want to compare structure, function, structure. And those two things,
they do cross paths.
I talk with my hands. They cross, right? They influence each other.
Absolutely. And so what we want to make sure is that we're attacking the functional issue first, and where we can in the most non-surgical way intervene, let's try that first. Now, if there's an emergency situation, failure to thrive, like we know this absolutely needs to happen like yesterday. Okay. But in most cases, we don't have that. And we can actually go to the functional provider. My second step after the functional provider says, look, we've worked together. We've tried to revise the latches, the holds. It's just not working out. Here we are, we're prepped, we're ready for the release. I love to see a good 1 or 2 visits where they're actually working on getting the parents comfortable with being intraoral, because a lot of the times after these releases, parents have to manage an active open wound. That's difficult. Can you imagine where the parent is by the time they've gotten to this point of the release? So maybe something didn't go so well with the pregnancy, or not the way that they thought it would. Maybe the labor didn't go the way they thought it would. Now their breastfeeding relationship isn't going exactly the way they thought it would. I mean, there's a lot of psychological things there too. Then you're going to do a surgical release on their baby and try to teach them afterwards how to do a intraoral wound hold. I mean, that's so bizarre to me. They're already so stressed. They're already uncomfortable with this. So
and what do we know about stress and learning? We don't do it very well. That is such an excellent point. Okay, so what you're saying, structure, assess the structure, determine the need.
Yes.
Do some functional work to see if we can loosen things up, strengthen things out. And again, unless there's a failure to thrive, in which case we're acting immediately. But if we're doing that, we're having a visit or two with the functional person so that the functional person can teach me, the mom or dad, how to get inside the mouth. That's what intraoral means.
Yes.
And manage what an open wound.
Open wound.
Yeah.
An open wound. Most of the providers are using lasers, and the lasers are cauterizing the tissue so that you don't get much bleeding. And so we're having an open wound that you have to manage. And so, baby's going to be uncomfortable. Mom and dad are already stressed and nervous, and now they have to get into a mouth, and maybe they have no familiarity with being in someone else's mouth before. So you've got to really get everybody in tune and feeling comfortable and confident. That way you get the best outcomes. And so I would have that work done first and then release. That way, afterwards, you're able to get back to your functional provider, heal, and now work again on functional goals, because a lot of people expect it to be a miracle snip or a miracle surgery. You got to still go back to function.
This is okay. So again, right? We can fix structure and not have fixed function. This is like so wild. And so it really is this. I mean, the part of the reason I think myofunctional therapy is so interesting and also so confounding and complicated for people is because it is this like swish of a loop of an integrated approach where we're looking at, I mean, and if you watch back even on this video, all of the things that you mentioned that can result from a tethered oral tissue, right? Posture, breathing, grinding, feeding. There are a number of things that we're really just beginning to learn about that are affected. And so, and just fixing how we are formed is not going to fix it, particularly not in older kids or adults when we've developed a lifetime of patterns.
Exactly. Because the patterns, it just all compounds as you age. It's not easier to unwind all of that. It actually gets more complex. And so you have to do all the other stuff. And I think it's a little bit misleading when the media, I think there was a New York Times article like 2 years ago where a child got a frenectomy, a nonverbal child got a frenectomy, and then magically they were speaking immediately after. I mean, that's a 1 in a million case. We could have had that kid win the lottery too. Kid could have done that just as easily. But, it's really not common. So you have to do the work. You have to do the work.
Is there I know there's no magic age, but I'm going to ask you the question anyway. Is there a magic age or interval in which you don't advise surgically intervening?
Yes. And there's a bit of a caveat to it. So yes, there is an interesting age kind of between 1 to about 3 where they're not very cooperative, for the best, nicest word that we can use. You're kind of in that toddler stage where they do what they want. We're on their time and we move at their will. And so trying to get active wound management on a toddler without causing undue trauma, stress in the home, and some sort of injury, because toddlers, I don't know if anybody's ever been bitten by one, but they bite down with a vengeance. Like they bite with intention. So trying to get hands in a mouth of a toddler is not
I mean, that alone, honestly,
yeah,
from a practical perspective, such a good point. Like, let's not do intraoral work against a toddler's will, because they will chew you up.
They will mercilessly. You feel like, ow, this really hurts, and then they bite harder. It's a very odd phenomenon. But in that age group, unless they're getting it done by an ENT, an oral surgeon, or somebody who's putting them under general anesthesia, because that's the only way that they would be able to get sutures, to manually close the wound and to manually help with the healing process, I'd say just you got to tough out that period of time.
And then we're sort of dealing on I keep doing my hand thing, but we're sort of dealing on the functional side until we can get sort of a behavioral compliance to work on the structure.
Absolutely. Absolutely. Because once you hit like 3, 3.5, 4, they can start doing some exercises. They'll move their tongue around. They will move for reward, they will do things in order to comply. But before then, oh no, all bets are off.
Yeah. Right. And so we're talking about babies and or then older, slightly older kids. It's so interesting to me, this toddler set. There's like, I have often had 2-year-olds who I suspect there's some kind of breathing issue or a hearing thing, but an ENT, for example, doesn't want to scope a 2-year-old for that same reason, because they're more likely to hurt the kid than they are to find out anything useful. And so it is this kind of gray area where we're kind of waiting for maturity to come online so that we can explain what it is that we have to do, if in fact we do have to do it, which is another reason to wait, because do we really have to do it?
Exactly. Exactly. If you could get some functional gains in the interim, I think that's really the best way.
Mm-hmm. Mm-hmm. What are some benefits, long-term benefits? And I think we discussed them earlier, but as risks, but let's frame them as in terms of benefits. What are some long-term benefits of having a tongue tie revised if we need it?
If you get it revised, should you need to, you might be preventing yourself from having certain issues with speech and speech production. You might have some ability to now remap, because in a lot of issues where we have the tongue tethered, especially when it's more in the front that it's tethered, now our mapping, our sensory mapping gets a little bit off, right? So sometimes we have hyperactive gag reflex, so you might be avoiding that. And you might also be avoiding some of the picky eating, because now they're able to actually have foods on the molars where they actually get to crunch those foods up, those hard crunchy foods. So you might be able to avoid some of that too. As you get older, we're talking about orthodontics, so that's braces, the need for such, so malocclusion you may be avoiding, the sleep issues, some digestive issues, because oftentimes if they can't chew properly or move the food properly or breathe properly, they're swallowing a lot of excess air, or the salivary content is not very good, and we get a lot of disruption in the gut flora. And so you're preventing a spectrum of things.
Mm-hmm. And this is what makes
it,
again, this whole field is fascinating. But what's interesting about what you just said is preventing, right? Because we can never prove something that didn't happen.
Very true.
Very and so true. I do think this is where who you see matters.
Yes.
What they know matters. How educated you are in like this is really where provider and consumer need to meet each other in terms of what's best for the individual person and sort of the case that we're seeing. And that's age and stage and function and structure. And it's all of those things thrown in there, along with a family history and right, other kinds of things, because when we're operating, it seems very obvious to me anyway, that if somebody is autistic and not speaking, it seems very obvious that we are changing the course of history, and that future seems much dimmer if we don't do intervention.
Yes.
In this case of a tongue tie, or even if we don't know, right? We're not really sure what we're preventing most of the time. Is that true? Is that fair?
100%. You never really know. You never really know. You know, I think we talked about it a little bit with my children and their different manifestations, like all of them, same genetics, same household, same eating diet, whatever, different manifestations based upon how it was going for them. So you never know what you're going to get. You don't know what exactly you're going to prevent. But what we do know is that if we can prevent some future distress or harm to our children, most of us are going to go for that.
We absolutely are. And I'm going to leave it right there. This was so helpful. Thank you, Karese. I appreciate you coming back to
I loved it.
Educate us on the tongue ties. Thank you.
No problem. Thank you.